Thank you for joining the November Korean DC&R discussion forum. Today we will talk about the malignancy associated with colitis. We invite Ryo Sensei and panelist. As a panelist, we invite Chiyoshi Konishi and So-hyun Kim and Jong Lee from Korea and Japan. 11월 DCI 프롬에 참석해 주셔서 감사드립니다. 오늘은 유씨와 관련된 말리그넌시에 대해서 일본의 세이시마 료 선생님께서 작성하신 논문을 가지고 토론을 진행할 예정이고, 한국에서 이종률 교수님, 김소영 교수님을 패널로 초청드렸고, 그리고 일본의 츠요시 고니시 선생님이 그 패널과 통역을 겸해 주시겠습니다. 세션은 1시간 동안 진행이 되고 영상은 녹화해서 유튜브에 게시가 됩니다. 오늘 참석 못하신 경우는 유튜브에서 다시 한번 확인해 보실 수 있습니다. 질문은 한국어로 해주시는 게 좀 통역이 편할 것 같습니다. 지금 오디언스는 그 비디오가 꺼져 있는 상태라서 이후 그 디스커션 시간에 그 손을 들어주시면 토론자 수준으로 변경을 해드리도록 하겠습니다. This session will run for 1 hour. Session will be recorded and uploaded at DCR YouTube channel. If you are not Korean, feel free to ask in English. We can translate, not we, just Young can translate in Korean and translate, and also the Konishi will translate in Japanese. 네, 지금은 예전과 다르게 다 이제 참가자들은 음소거 되어 있고 비디오가 비활성화되어 있기 때문에 질문하실 게 있으시다면 꼭 손을 들어주시면 감사하겠습니다. Okay, so webinar etiquette. Okay, I'd like to introduce our panelists first. Konishi Chiyoshi is very famous. He's working now in the Andes Cancer Center. Just Chiyoshi, please say hello to Korean audience.
Yes, thank you for joining. Thank you for inviting to a wonderful Korean forum, and also, I would appreciate, this, you picked up the Japanese paper from DCR, so I look forward to the discussion.
Thank you. And next, So-hyun Kim. She is now working at the Yeongnam University Hospital, and she is very important role in the Korean Inflammatory Bowel Disease Society. 소영 김소영 교수님,
Thank you.
짧게 인사 부탁드립니다.
네, 초대해 주셔서 감사합니다. Thank you for joining this meeting.
Next, 이종률 교수님입니다. Okay. Next is Jong-il Lee. He is now working at Asan Medical Center. Asan Medical Center is actually one of the big center to treating the inflammatory bowel disease as a surgical approach. Please, Jong-il Lee, say something for our audience.
예, 이종률입니다. 패널로 초대해 주셔서 감사드립니다. 제가 감기 걸려가지고 목소리가 너무 안 좋은 점을 좀 양해 부탁드리고요. 최근에 몇 년 사이에 이제 IBD 어소시에이트 인테스타인al 캔서에 대해서 일본 그룹이 워낙 페이퍼들을 많이 시리즈로 내고 있는데 그 중에 한 편을 선정해 주셔서 이렇게 재밌게 진행해 주셔서 너무 감사드립니다.
He got cold, but his voice is very good. It's okay for us, all of us. Okay, as you saw, Young-il Kim will translate our conversation in English. Young-il Kim, please briefly say hello to our audience.
Hello, it's always nice to see people here. I'm translator as you always, so I'm looking forward for the fun topic as well. Thank you.
You can talk and you can talk your opinion. It's okay.
I'll just stay as a translator.
Okay, I see. And actually, finally, I'd like to introduce special guest, Sensei Ryo Seishima Sensei. He is now chief of Keio University, the Department of Surgery. He's very good. He's very expert for nationwide database research, and also the many papers he published regarding the COVID areas and also young and late on the cancers and some research topics. He's very, active in Japanese the society as well as he's a very best research in the field of colorectal disease. Dr. Seishima, please introduce yourself very briefly and say hello some words to our audience.
Thank you very much. I really appreciate your kind introduction. My name is Ryo Seishima from Keio University, Japan. I'm very honored to present our study in this prestige meeting today. Thank you very much.
Thank you. Today's topic expresses a prognostic benefit between the extended and segmental colectomy for patients with neoplasia associated with ulcerative colitis, nationwide multi-center studies. 굉장히 재밌는 주제입니다. 유씨와 관련된 말리그넌시에서 암에서 이제 세미널 리섹션과 익스텐디드 리섹션 중에서 어떤 것이 예후에 더 이점이 있을 것인가에 대한 내용입니다. I ask Dr. Seishima to present it briefly, summarize his study in 5 minutes. Could you summarize your study briefly, Seishima?
Okay, thank you. I'm going to present my.
Have slides?
Yeah, I have slides. Can I share the present?
Sure, yes. Okay, now you can share.
Can you see the slide?
Yes, of course. Great.
Thank you very much. So, okay, again, thank you so much for inviting me this meeting. So although the gold standard approach for neoplasia associated with ulcerative colitis, NAUC, is considered to be extended colectomy, segmental colectomy is becoming more accepted as a surgical option. So there's a need to re-evaluate the significance of extended colectomy because it may impact the patient's quality of life. So this study aimed to assess the prognostic benefits of extended colectomy in patients with NAUC by using a nationwide database. This was a multi-center retrospective cohort study, including patients with UC who were diagnosed with intestinal neoplasia between 1983 and 2020. Data were collected from 43 institutions across Japan. Patients' selection strategy is shown in this slide. Out of 879 patients, 801 had NAUC and 78 had sporadic colorectal cancer. These pathological diagnoses were based on institutional pathological reports. We categorized surgical procedures into two major groups. One is the extended colectomy group, which included total proctocolectomy, which refers to APR, IAA, IACA, and subtotal colectomy with rectal preservation. The other group is the segmental colectomy group, which included all other procedures. Here we show the clinical and oncological backgrounds of patients with NAUC, comparing extended and segmental colectomy groups. Segmental colectomy group were older than extended group and had less mucosal inflammation. And in terms of oncological findings, both groups were comparable. This slide summarizes the survival outcomes among NAUC patients. In both overall and disease-free survival, extended colectomy showed better prognosis. In terms of recurrence sites, the segmental group showed higher rates of recurrence in the residual intestine, which is as expected, but there was also a numbers of metastasis to other sites. In multivariable Cox regression analysis, extended colectomy was an independent factor associated with a better long-term survival. Next, we analyzed UC patients with sporadic colorectal cancer, which was pathologically diagnosed. Again, there were significant differences in age and inflammation scores, and also the number of lesions between the two groups. In contrast with NAUC, in this particular subgroup, there was no significant difference in survival outcomes between extended and segmental colectomy. So this implies that the prognostic benefit of extended colectomy may be associated more in NAUC patients than sporadic cancer patients. This slide shows the studies on surgical procedures for IBD-associated cancers in the past. Numbers of studies have shown the prognostic benefit of extended colectomy, considering the risk of metachronous cancer in the residual intestine, which is consistent with our study. However, only few large-scale studies have focused exclusively on UC, and it is unclear whether NAUC was diagnosed pathologically. So in this study, we try to address these problems. There are some limitations in this study. One is that this was a multi-center retrospective study with a potential for selection bias. And also there was a very limited number of patients in the segmental colectomy group. And there should be also the variations in surgical indications or pathological diagnosis among institutions. However, we have strengths, which is that this was a large population-based study evaluating the role of extended colectomy in the setting of pathologically diagnosed NAUC. So this study showed the association between extended colectomy and better prognosis in pathologically diagnosed NAUC patients. The diagnostic accuracy of pre-operative NAUC was also considered to be important for treatment decision. This study was conducted as part of JSCCR project, and I sincerely thank all the members involved. Thank you very much.
Thank you. Congratulations for its very huge data and nationwide data. It's very meaningful. According to this data, as the extended resection is much more benefit for patients with the malignancy associated with ulcerative colitis. 사실 이제 UC에 대해서 일본 세그멘탈 리섹션을 해도 된다, 뭐 이런 이야기들이 이제 연구들이 이제 상당히 최근에 발표가 되었던 걸로 알고 있습니다. 근데 전체적인 오랜 기간에 걸쳐서 익스텐디드 리섹션이 이제 좋다라는 결과를 발표해 주셔가지고 요거 뭐 물론 레트로스펙티브 데이터이긴 합니다만 이게 정말 역시 뭐 클래식 킹인가 뭐 이런 생각을 하게 되는데요. Okay, I'm now just to summarize your research. 그렇다면 그 각 나라에서 지금 UC 어소시에이티드 말리그넌시에 대한 수술 트렌드가 어떤지가 좀 궁금한데요. 그에 대해서 우선 여쭤보도록 하겠습니다. I just wondering that the proportion of segmental and extended resection for UC-related malignant disease is changed in countries or not. Please, Dr. Seishima, just comment on how the surgical trend in the UC-associated malignant disease has been changed in Japan past 20 years.
Thank you very much for the question. I think it's basically recommended for the extended colectomy and not changed very much in Japan for these years. Actually, over 80% of the patients we analyzed was performed for the extended colectomy.
Okay. How about Korea? Could you comment on the Korean situation? Professor Sohyun Kim, could you please comment on that?
사실 지금 아마 기관마다 차이는 조금 있을 것 같기는 한데 저희는 일단은 익스텐디드를 가장 레커멘드를 하고 있고요. 그렇지만 그 환자분들 중에서는 그 거부감을 가지시는 분이 꽤 있어서 사실 그런 환자에서는 아주 선택된 그룹에서 일부에서만 세그멘트 리섹션을 시행하는 것으로 알고 있습니다.
So in Korea, it might be different according to each centers, but in her center, in Professor Kim's center, she normally recommends extended colectomy. She performs only in small selected patients for segmental colectomy who doesn't want extended colectomy.
Yes. 이종률 교수님께서 최근에 이 UC를 모아가지고 그 디스플레이자의 선을 발표하셨던 것도 제가 봤었고요. 그래서 이 연구를 좀 하고 계신 걸로 쭉 하고 계신 걸로 알고 있는데, 여기에 대해 코멘트를 부탁드립니다. The journal is published some couple of studies on this topic that he can on his current situations changing.
우선 congratulations on the excellent result, Professor 세이시마. 이제부터 한글말로 하겠습니다. 목소리가 너무 안 좋아서. 저희 결과는 단일 기관 연구 결과로 클리니컬 콜렉탈 캔서라는 잡지에 게재를 했고요. 사실은 이런 내셔널 데이터가 아니라서 아마 내셔널 데이터에서 포함할 수 없는 디테일드 아나리시스를 시행해서 사실은 좀 다른 결과를 보인 것 같습니다. 근데 아까 질문 주셨던 것처럼 익스텐디드와 이제 그 세그멘탈 콜렉토미 부분에 있어서는 사실은 저희 기관에서는 개념적으로는 일단 기본적으로 익스텐디드 콜렉토미 대부분 했기 때문에 세그멘탈 콜렉토미 케이스는 한 10% 남짓밖에 되지 않습니다. 그래서 이런 비교는 조금 그냥 모든 것을 다 베리어블 매칭할 수 없기 때문에 이런 결과들을 조금 정확하게 이야기하기는 힘들 것 같습니다.
So, Professor Lee performed a single center analysis from Assam Medical Center, and it was about UC dysplasia and extended colectomy and segmental colectomy. But like the data from the Japan, most patients performed extended colectomy, about more than 90%. Only 10% patients received segmental colectomy. So he also says that the data that we have can't actually directly compare between the two groups.
이제 논문으로 이제 좀 들어가 보겠습니다. 이 논문에서 보면 이게 수술 방법이 멀티베리어블 아날리시스에서 독립적인 예우인자로 나타나긴 했는데 그 종양 자체에 대한 정보가 사실은 이게 충분히 있지는 않다라는 생각도 들고 굉장히 오랜 기간에 걸쳐서 이제 데이터가 수집이 되어서 그동안 종양 치료에 대한 이제 언급이 이제 충분치 않아서 이런 것들이 영향을 미쳤는지 좀 알기 어렵다는 생각이 좀 들었습니다. 그래서 여기 이제 그 UC-associated malignancy에서는 그 종양 자체에 대한 그 캔서에 대한 어드밴트 트리트먼트나 이런 것들의 컨셉이 좀 다른지에 대해서 좀 논의를 해보는 게 좋겠습니다. Dr. Seishima, I read the research. I realized that although the surgical the extent is indeterminate variable in multivariable analysis, although I cannot find the detailed pathologic staging, although the pathology stage is a dependent risk factor in multivariable analysis. Just you show the T0 to 2 or T2 and 0 and positive is actually more severe in segmentalization. Therefore, the tumor status is and the adjuvant treatment. You collected the data along the 20 years. The treatment of colon cancer has been changed apart during. It cannot reflect the treatment for cancer itself. Just therefore, so we need to talk about the adjuvant treatment of UC-associated cancer is somewhat different from the sporadic cancer. We need to talk about this point. Do you have any, actually, what you said? It would be different because the genetic base for UC-associated malignancy is a little bit different from the sporadic cancer. Therefore, the adjuvant treatment and the other type of treatment can be different from the sporadic cancer.
About the adjuvant chemotherapy, I think it's still a very controversial issue that honestly, I don't think we have a conclusion for the recommendation in this in Japan too. In my institution, I think it's done according to the normal sporadic cancer regimen, but I'm not really sure other institutions how other institutions perform the adjuvant chemotherapy.
Yeah, I agree with Dr. Seishima. Actually, Japanese guideline do not really distinguish, UC versus non-UC associated cancers. So I think basically our indication for adjuvant chemotherapy is based on the pathology, the positivity.
The
Yeah.
sort of stage. Okay. Okay.
Yeah.
How about Korea?
In Korea, we also followed sporadic colorectal cancer, even in the UC associated colorectal cancer. But in this paper, the results showed quite there was no significant difference between the UC associated colorectal cancer in the extended and the segmental colectomy. Is it right? Teishima sensei.
Thank you. In the sporadic cancer patients, yes, as you mentioned, there was no prognostic difference.
I mean the
Proportion
patient
of
only
adjuvant
who
treatment.
yeah, right.
Sorry?
Yes, less than 20%. Less than 20%. It's the extended recession is 19.7 and the segmental for the 14.6 and so something. So less than 20% of patients received adjuvant treatment. I just
한국에서도
yes wonder
예.
the segmental recession patients are a little bit advanced stage.
Yeah,
A little
I
bit
agree
advanced.
with that. Yeah, a little
Yes,
bit
yes.
advanced.
Yeah, but the adjuvant chemotherapy was less given to the sporadic segmental resection.
근데
I
사실
see, I
궁금한
see.
점이 하나가 있는데 TPC 했던 거하고 토탈 콜렉토미 했던 거를 서플리멘트 테이블 1을 보면 사실 어줌트 말씀 주셨던 것처럼 어줌트가 보면은 토탈 콜렉토미 했던 환자가 30% 되긴 하더라고요. 보면은 물론 서플리멘트 테이블에는 p-밸류를 주진 않아서 그 말씀 주셨던 게 지금 내셔널 데이터라서 아마 전체를 다 이렇게 디테일드 아나리시스 하긴 힘들지 않았을까라고 생각이 되겠습니다. 이 페이퍼에 대해서. 영일 Kim, please.
So he's questioning that if you look at supplementary one table, comparing the TPC total protocolectomy group and the total colectomy group, the total colectomy group received 30% of the patient's adjuvant chemotherapy. So, but it doesn't have any p-value. Can you comment on this, please?
It's actually a hard question. So this is one of the limitations of this study, that the treatment decision are different among the institutions, and we cannot know why the chemotherapy are applied to those patients and not to those patients. So yeah, it's better to focus on that point in the future. But yeah, I think that's a big limitation of this study.
네,
I think,
이철기님 말씀하신 것처럼. 예.
sorry.
네,
Yeah,
네.
just adding to his point. So I think when we look at the data, we really need to think why such huge prognostic difference happened between the segmental versus extended resection in the country where all the UC patient basically should receive total colectomy, right? So this segmental resection group is a very special cohort. There is some hidden reason why this segmental resection was chosen for these patients, and it unfortunately in this data set it's a retrospective study, so we cannot tell, but maybe some poor performance status or some other risk, or maybe more advanced tumor, I don't know, or maybe maybe some poor institutional level which cannot afford some complex surgery, whatever the reason is. Maybe I believe this is part of the bias rather than the entire reason, but still this bias significantly contributed to likely the proportion of adjuvant therapy, right? So if the patient is in a post performance status, they cannot receive adjuvant chemotherapy as well. So maybe the segmental resection will be the best that the patient was able to receive. So these kind of maybe some hidden bias could be presented. I think that's what the Dr. Seishima really wants to mention. Yeah.
Yes, that is the point. The segmental resection is much advanced disease, but less received adjuvant treatment. In terms of disease-free survival, it is acceptable, but how about the overall survival? It's, Juyoshi mentioned that they have some the influence on the overall survival. We cannot find out any mobility in this table or in this results, but it's one of the point. Very good point.
질문이
예.
But still, I think, the beauty of this paper is actually, although, the paper does not show detailed post-operative outcomes like a complication, but at least the oncologic outcome seems like quite reasonably good. Even, although we generally think that ulcerative colitis associated cancer has a poor prognosis, especially in the stage 3 cancer, as I think it was 10 years ago or more. Dr. Watanabe, used the older JSERS paper and data set, and he showed, poor oncologic outcome in a UC patient compared to the sporadic. But more recently updated, this cohort really showed a very good outcomes. I think for for this continuous JSCCR guideline based continuous efforts, I think the outcome of ulcerative colitis seems like getting better compared to the prior studies.
네, 다음 질문으로 넘어가기 전에 일단 김여일 교수님께서 간단히 대화를
예,
서머리 해주실 수 있을까요? 예.
어주번 트리트먼트 차이가 나는 거는 두 분 다 공통적으로 말씀하시는 게 이제 이게 후양적 데이터고, 세그멘탈 리섹션을 받은 환자가 굉장히 적었기도 하고, 굉장히 특별한 코호트일 텐데, 이게 어떠한 이유로 그 사람들을 골랐는지 정확하게 알 수가 없기 때문에 아마 환자의 제너럴 퍼포먼스가 떨어져서 뽑았다든지 뭐 다른 그런 영향이 있었을 거라고 말씀을 해주셨고요. 이 연구의 장점은 이제 비록 UC 관련된 캔서임에도 불구하고 이전에 나왔던 연구들이랑 조금 다르게 결과들이 스포레딕 캔서에 비해서 아주 나쁜 것 같지는 않다. 그래서 지금 추세를 보면은 UC 관련된 캔서의 결과가 좀 좋아지고 있는 거 아닌가, 이런 걸 보고 좀 좋다는 생각을 하셨다고 했습니다.
네, 이종률 교수님 질문 좀 궁금한 거 말씀해 주셨습니다.
예.
예.
그 리미테이션에 보면은 사실 제가 메소드에서 찾지 못했던 부분이 패톨로직 다이agnostic 프랙티스에서 조금 다양성이 리미테이션이라고 언급을 주셨는데, 이 내용이 이제 그러면 이 진단의 뭔가 퀄리티가 틀린 건지 기관들마다, 그럼 이게 이 연구가 굉장히 내셔널 데이터임에도 불구하고 리얼월드 데이터임에도 불구하고 일단 시작점에서 굉장히 흔들릴 수 있는 이런 리미테이션을 주셔서 그 이야기가 그냥 디스플라지아 UC 어소시에이트 콜렉터 캔서 진단에 대한 이야기인지, 아니면 뒤에 언급하셨던 것처럼 UC 어소시에이트 콜렉터 캔서가 아닌 스프레딕 캔서 그 자체의 구분을 이야기하시는 건지가 좀 일단 시작점에서 궁금했습니다. 영일 킴 플리즈.
So, Professor Lee is talking about the limitation. Dr. Seishima told us the pathologic report or pathologic diagnosis can be different among centers. So he's concerned that this might be a very important issue, because if it's related to different diagnostic, pathologic diagnosis regarding UC-related cancer or NAUC, then it might be very a concerning issue. But if it's just about diagnosing sporadic cancer pathology, then that might be a little better. So can you comment on this? So what do you mean by the different pathologic diagnosis of different pathologic reports among centers?
Thank you very much. So that's one of the big concerns. But in Japan, the pathologists generally see the inflammation in the background of the cancerous lesion, or the morphological differences between the sporadic cancers, and also the staining, immunohistochemical staining for P53 or Ki67. Those are generally used for the pathological diagnosis. I believe that there's no big difference, but it's still really one of the concerns that we might be cautious.
그래서 큰 문제일 수도 있긴 하지만 일본 병리학자들은 이제 보통 이제 그 UC랑 스포라딕 캔서를 볼 때 염증 부분을 확인을 하고 IHC에서 P57이랑 KI67을 그 확인을 하는데 본인이 생각했을 때는 아주 큰 차이는 없을 거라고 생각은 하지만 그래도 이 부분이 이제 뭐 RCT도 아니고 후양적인 연구이기 때문에 아마 그런 이유 때문에 이렇게 제한점이라고 말씀하신 것 같습니다.
사실 한국에서는 KI67을 루틴으로 보지는 않거든요.
말씀드려야 될 것 같습니다.
Oh, so he commented that in Korea we don't routinely look for KI67.
네, 김소영 교수님.
사실 저도 그 부분이 조금 궁금했었는데, 제가 알기로는 사실 UC 베이스드 NAUC와 사실은 스포라딕을 명확하게 사실은 구별할 수 있는 방법은 없는 거로 알고 있거든요. 사실 크라이테리가 명확하지 않은데, 사실 20년에 걸쳤는 환자를 일노를 했음에도 이렇게 어떻게 이거를 이렇게 나눌 수 있을까가 사실 저도 개인적으로 제일 궁금했고, 사실 이 연구를 하고 나서 그럼 이제 결론적으로는 저희가 이제 세그멘탈 리섹션을 해도 되는 그룹을 조금 셀렉션 하는 게 중요할 것 같은데, 여기 이제 연구하셨는 선생님께서는 이제 실질적으로 환자를 볼 때 어떤 환자에서 세그멘탈 콜렉토미를 레커멘드 하시는지 한번 여쭤보고 싶습니다.
Yes, Dr. Kim was also concerned of the similar issue Professor Lee asked. She's curious about, is it really that definite to diagnose NAUC from sporadic cancer? Because she thinks it might be a little hard, ambiguous at some points. Is it really that black or white thing? That's one question. And another question is, for the segmental resection, please, Dr. Seishima, which patients would you select for performing a segmental resection for NAUC?
So you mean in this cohort we analyzed?
In practice general, she asked.
In practice. So personally, in our institute, we basically never performed the segmental colectomy. Yeah, if we detect some cancerous lesions in the colon rectum, we basically perform the extended colectomy. And sorry, what was the
first question? Was is it really that clear to diagnose NAUC? Yeah.
So yeah, I think that's a very hard issue. Yeah.
末島先生、よかったら、このスタディでどういうふうにスポラディックと、UC のがんを分けたのかって、例えば、微妙な症例っていうのは多分施設ごとにあったと思うんですけど、なんか、プロトコールがあったのか、それとも完全に何かガイドラインスみたいなの見せたか、そのあたりの、このスタディに関するものをちょっと。
ありがとうございます。ちょっと日本語で失礼します。基本的には、ガイドラインにのっとった、診断が各施設でなされているものを、レトロスペクティブに、収集した情報になりますので、やはりちょっと詳細な、診断過程というのは、わかりかねるかと思うんですけれども、このスタディの、やはり、新規性といいますか、重要な点は、こういった病理学的な、診断で NAUC だけを抽出したような報告っていうのは、これまでほとんど例がないというところにあるのかなと。
UC を多分彼は聞いていて、その NAUC をどう、やっぱり完全に白黒分かれるものじゃないので、どう分けたのかっていうのをちょっと聞きたいみたいなんですけど、何か情報ってありますか？
ちょっと、はい、40年前のデータも含まれてますので、ちょっとそこは、はい、申し訳ありませんけど。
完全にその病理のレポートに基づいて。
そうですね、はい。
Okay, I'll translate. So, actually, during this study, also they were concerned about, this really obviously, the UC associated versus sporadic cancer in the ulcerative colitis patient is, not a black and white, but there's some gray, matters, right? So, but this study included not only a recent one, but even a patient 40 years ago. And this is a retrospective study. So per the study protocol, they were forced to, look into only the pathology data and the pathology report in each institution. And basically in Japan, it's a very, there's a strict guideline, pathologic diagnostic criteria, how to report the colorectal cancer and how to report the ulcerative colitis. So basically, based on the immunohistochemistry as well as inflammation status, basically each institution, the pathologist really, at least, mentioned whether this is a sporadic versus whether this is more like an ulcerative colitis associated, and basically they follow that, but they cannot get more information, unfortunately. And obviously, this is the one of the limitation, but at the same time, he also emphasized, Dr. Seishima emphasized that, although there are a lot of studies that investigating on the outcome in ulcerative colitis associated cancer, but there's not many studies that distinguished sporadic patient versus true ulcerative colitis associated, or at least suspicious of this UC derived cancer, and distinguish them and show the outcome. That is that is a novelty in this paper, and they showed a very different trend in prognosis between the extended resection versus segmental resection. So I think this is something that he really want to emphasize in this study. Yeah.
예. 그래서 일본에서는 세그멘탈 콜렉토미 거의 본인 센터에서는 거의 안 하신다고 말씀을 하셨고, 이 연구진들도 이 연구를 진행을 하면서 같은 우려를 해가지고 이 NAUC와 스포레딕을 어떻게 명확하게 구분을 할 것인가를 살펴봤다고 말씀을 하시는데, 당연히 그레이존이 있기는 있겠지만 일본에서는 굉장히 엄격하게 병리 리포트를 하는 가이드라인이 제시가 되어 있고, 각 기관에서 꼭 그 UC와 관련된 것인지 아니면 스포레딕 콜레렉탈 캔서인지를 보고하게끔 돼 있어가지고, 그거에 따라서 연구를 설계를 했다고 말씀을 하시고 있습니다. 근데 물론 이제 후양적 연구이기 때문에 완전히 정확할 수는 없지만, 다른 여태까지 나온 UC 캔서 관련된 연구들을 보면은 이렇게 UC 관련된 암과 스포라딕 캔서를 명확하게 구분을 해가지고 보고한 게 없기 때문에 이것이 가장 큰 장점이라고 말씀하셨습니다.
그럼 자연스럽게 이제 다음으로 보면 이게 서지컬 인디케이션에 대한 부분을 조금 질문을 드리고 싶은데, 그러면 이제 이게 리얼월드 내셔널 데이터니까 그러면 이 JSCCR에서는 그러면 가이드라인으로 이제 이 결과에 따라서 멀티베리어블 결과에 따라서 다들 그냥 토탈 프록토 콜렉토미, 익스텐디드 콜렉토미로 가는 게 맞는지가 첫 번째 질문이고요. 두 번째 질문은 개인적으로는 이게 정말 세그멘탈 리섹션 했던 군하고 익스텐디드 콜렉토미 했던 군이 정말 이게 같은 환자군이 아니어야 될 것 같거든요, 인디케이션이. 이 프리시즌 메디슨 시전에서 이 정말 그 UC 익스텐트가 낮고, 메이어 스코어가 좋고, 그 다음에 환자가 정말 익스텐디드 안 해도 될 만한 환자들이 있을 것 같은데, 꼭 이걸 다 익스텐디드로 가야 되는 게 결론을 내는 게 맞는지에 대한 질문을 좀 부탁드립니다.
So, Professor Lee is asking, naturally, we have to go to the surgical indications after this study. It's a big study, real world data. So, is the JSCCR recommending every centers in Japan to perform extended colectomy for UC-related cancer? That's one question. And if we look at this data, there is a benefit for segmental resection, not a benefit, but not inferior outcome for doing segmental resection for sporadic cancer. So can we select some patients for segmental section, or do we have to do extended colectomy? So do you have a method to select the patients for segmental colectomy?
Okay, thank you very much. So from other reports in the past, basically, the segmental colectomy is um, it can be done to especially the elderly patients or the less inflammation surrounding in the surrounding mucosa. I think those are the factors that we need to consider. In the Japanese guideline, I think it's still the recommendation is the extended colectomy for NAUC patients, but there's also a description that we need to think about the patient's backgrounds, social backgrounds. I think that includes the age of the patients, the comorbidities of the patients, performance status. So it's not really clear, still not clear, but I think that's the situation in Japan now.
네, 그래서 그 일본 가이드라인에서는 엑스텐드 콜렉토미가 계속 있는 거는 맞는데 환자 백그라운드를 생각을 해야 되고 나이, 코모비디티, 제너럴 퍼포먼스 이런 거를 생각을 해서 해야 되는 거기 때문에 꼭 완전히 이렇게 막 토탈 콜렉토미 엑스텐드를 해야 되는 걸로 이렇게 고정을 시킬 수는 없다고 말씀하셨어요.
네, 지금 이제 온콜로직 아웃컴이 다르다는 게 조금, 온콜로직 아웃컴이 좋다라는 게 이 논문의 가장 큰 포인트가 될 것 같은데, 오벌 서바이벌이 다를 수 있는 이유는 이제 셀렉션 된 세그멘탈 리세션 한 환자들이 기본적으로 나쁠 수 있다라는 점에서 이해가 가지만, 이제 디지즈 프리 서바이벌은 조금 다른 문제이거든요. 요 디지즈 프리 서바이벌을 계산할 때 이거 메타크로노스라고 해야 되나요? 이제 메타크로노스라고 봐야죠. 메타크로노스 캔서가 포함이 된 것인지, 리얼 리커런스나 메타스테이스나 포함된 건지, 그런 부분도 좀 점이 될 수 있을 것 같습니다. Professor Dr. Seishima, I just wondering is the poor overall survival in segmental resection would be acceptable because the basic patient characteristics would be worse than the patients who undergo the extended resection. But the digital survival is quite different in a problem because a real oncologic thing. I just wonder, do you have any information for site of recurrence of a site of metastasis, or do you include any metachronous, colon cancer as one of the metastatic site in segmental resection patients?
Thank you. We have the data about the metastatic sites, which I showed in the slides today. There are about, sorry, I forgot the actual number. 10% of the patients had the metastasis in the residual intestine. Since we could not analyze the cancer-specific over the survival, I'm not sure whether those metastatic sites really affected their prognosis.
Oh, yes, I'm sorry I missed this slides, but the 10% of segmental resection, 10% of recurrence in segmental resection is in the residual intestine. Except this, I think is if you exclude the residual intestine, the real metastasis or real recurrence is that quite different.
Yeah, I didn't show in the paper or today's presentation, but there's still a quite big difference, even we exclude the residual, the metachronous cancers.
Yes, okay. I
So I
noticed the peritoneal metastasis is much more higher in segmental resection patients. Do you think
Yes.
the special reason for this?
Not sure. Sorry. Yeah, but these patterns of the recurrent sites quite different from the extended and segmental colectomy was one of the curious findings in this study.
Yeah, I think maybe if we, think about other possible reason why such a huge oncological difference exists between these, procedures, and I think again, we need to think about why when we actually choose the segmental resection. For example, for stage 4 patient, we choose the segmental resection, right? Because there's no role for prophylactic colectomy anymore. When the patient has a left segment, left colon cancer, and the left side colitis, maybe better right side, I would definitely choose left side colectomy. And I think, although this study did not include stage 4 patient, but some quite terrible, we can imagine some of the ulcerative colitis cancers are terrible, right? They are basically mucinous cancer and often has a quite a advanced disease, locally advanced disease. And for these patients, which is expected to have a very poor outcome, we tend to actually choose the less less extended resection, like a segmental resection. So maybe there, and it's not only the stage, but maybe EMVI or other factors. But obviously, it's not surprising if this segmental resection group has much more baseline advanced disease. So that's why I think these, the recurrence also was higher in this group. So what I want to say is likely, this is not the cause and the effect, but rather, maybe the opposite. Maybe there was some baseline difference. That's why they chose the segmental resection. At least, when I look at the data, I would interpret the data like that. Yeah.
But Chelsea, we can see that in multiple analysis actually stays in surgical and both are the independent risk factors for the
Mm.
poor, the disease-free survival and overall survival, both of them.
Mm-hmm. I
So
mean,
I just in the same stage, they can be just perform the segmental resection based on the file status. That's my point.
yeah, but this is a retrospective study. So even if we do a multivariate study, we cannot completely sort out the hidden background difference, right? And again, the cancer stage is not only, the stage 2 or stage 3, but there are many variable not included in the multivariate analysis. For example, this is including all the data, I mean all the data. So not all the patient had a baseline, modern type of
Detail.
radiology.
Mm,
So
mm.
yeah, I think that this really, higher peritoneal mets really highlight, maybe the background disease could be more advanced in segmental cancer, although, you know, uh, we cannot tell, we don't really know what exactly happened, but yeah, that's my guess when I look at this data. Yeah.
But I cannot do the segmental section. I have to read this paper to use it related to cancers.
Oh, but I think, if there's any, so yeah, that's a really good, interesting discussion. Which patient should we do segmental resection, or are we allowed to do? And maybe I'm more interested. What is the exact, situation that you choose segmental resection in Korea, actually? Yeah.
Okay, Professor Newly could you comment this?
예. 상식적으로 사실은 생각할 때 지금 논의하셨던 게 너무나 와닿는데, 근데 사실은 이게 멀티베리어블 리저치에서 지금 이 서지컬 인터벤션이 콘클루지브 아웃컴을 차이가 나게 했잖아요. 근데 여러 가지 가설들을 이야기해 했지만은 지금 이 결과 자체를 어쨌든 뭔가 그냥 가정을 해주시는 것 같아요. 근데 제가 생각하기에는 정말 이 서지컬 인터벤션이 어드밴스드 스테이지에서 정말 메타스타시스를 정말 차이가 나게 할 수 있을 거에 대한 우리 상식적인 걸 좀 생각해 봤으면 좋겠다는 의견을 드리고 싶어요. 무슨 소린가 있어요. 스프레드 캔서에서 스테이지 2, 스테이지 3, 3, 2, BC 이런 스테이징들에서 서지컬 롤이 정말 이렇게까지 오버롤 서바이벌과 디지즈 프리 서바이벌 차이가 나게 할 수 있을까라는 걸 생각해 보면 그렇지 않을 것 같다는 생각이 들거든요. 그럼 이 리서치에서의 멀티레벨에서 이 결과를 그냥 단순하게 저희가 그냥 받아들여서 이렇게 해야지라고 할 수 있지, 리얼 월드 프랙티스에서 할 수 있을까라는 고민이 들긴 합니다. 대답이 됐을까요?
그러면 서지컬 리섹션 자체가 실제로 이제 환자 프랙티스에서 보면 이 정도 온클로즈 아웃컴에 영향을 주지 않을 것이다 라는
아마
생각이신
이게
거죠? 네,
나라의 이런 차이도 있을 것
네, 네.
같아요. 왜냐면 일본은
음,
스몰 센터들에서 캔서 IPD를 뭐 1년에 몇 개씩 하는 센터들이 많이 모여서 이런 결과를 냈을 텐데, 그러면 이 세그멘탈 리섹션 할 때의 그 서지컬 퀄러티와 익스텐디드 서저리 했을 때 그 퀄리티가 같을 것이냐에 대한 부분이 하나 있을 것 같고요. 워낙 롱 히스토리를 가진 데이터니까. 그럼 이게 지금 최근에 트렌드 에코가 가이드라인도 돼 있지만은 스페셜라이즈 센터에서 익스텐디드 서저리라는 레코멘드가 있는데 일본 상황은 그러지 않을 것이라고 생각되면은 이 데이터들은 그런 게 다 녹아나지 않았을까라는 생각을 듭니다. 그래서 아마 리미테이션에서도 그 서지컬 아까 인디케이션을 쓰긴 했지만 서지컬 스킬에 대한 이야기는 쓰진 않았거든요.
at the same time, Professor Lee pointed out very interesting point. He talking about the surgical quality. He mentioned that the institutions perform the segmental resection as not that, the expert centers for the UC-related cancer resection. That therefore, the surgical quality can either in the poor prognosis, and so his opinion. So in my feeling, he thought that he's thinking in surgical resection extent itself is not the powerful the oncological outcomes, powerful influence on the oncological outcomes. How about the surgical quality issue?
小西先生、日本語でもよろしいですか？
はい、もちろんです。はい。
それは本当におっしゃる通りで、やっぱりスペシャリストがいない病院といる病院では、サージカルクオリティも、全く違う可能性があるということは一つ要因としてあると思うのと、あと、少し前のディスカッションで、ステージが変わらないのに、腹膜発症が多かったというような点ですけれども、これ2021年の杉田先生らの論文で、日本からの論文になるんですが、ステージ3にその論文ではステージごとの、比較をしていて、ステージ3でのみ、予後に差が出たと、エクステンデッドコレクトミーのが良かったというような結果でしたので、もしかすると進行するに従って、いわゆるステージ分類では表現できないような悪性度というのが、もしかしたらあるのかもしれないということをちょっと、皆様の話を聞いてて思いました。
ステージ3で何が悪かったんですか？ごめんなさい。
セグメンタールの方が
悪かった。
はい
エクステンデッドよりですね。はい、
はい
わかりました。Okay, first of all, actually, Dr. Seishima fully agree with the Dr. Lee's comment. Institutional, difference could be quite a big factor that led to this difference. And especially, the ulcerative colitis is a very rare disease in Japan. And there are not all the institutions have, the experts. And the institution without expert could have led to choosing a segmental resection, and eventually that might have led to more peritoneal metastasis or some technical failure, leading to other oncologic compromise as well. And also he also mentioned about another paper from Japan, authored by Professor Sugita. And in that paper, using Japanese data, they showed that actually the proportion of the difference of oncologic outcome between segmental versus extended resection is actually in parallel with the stage. In stage 3 disease, there's bigger difference compared to stage 1, 2. So maybe in ulcerative colitis cancer, he mentioned that there could be more something additional, especially in the stage 3 disease, So it's not only just a simple stage, but in stage 3 disease, there could be some, factor that worsen the outcome in a segmental resection. That's what he mentioned. Yeah.
One question, sir. Did you mean that segmental resection rates were higher?
Yeah. So
according to
the oncologic outcome of segmental resection is worse
worse.
in stage 3 disease. More in the segmental resection shows a worse outcome, and this worse outcome, the difference of the outcome was bigger in a more advanced disease like a stage 3
Okay.
disease. Yeah.
Yeah, I understand.
Mhm.
So 세이시만 선생님도 동의하신다고 말씀을 하셨고, 기관마다 차이가 큰 요인으로 적용할 수가 있고, 특히 UC가 굉장히 일본에서 흔하지 않은 병이기 때문에 저볼륨 기관에서 그 세그멘탈 리섹션을 더 많이 하고, 그래서 생존율에 차이가 나고 리커에 차이가 날 수 있다고 말씀하셨습니다. 그리고 또 하나는 스기타 선생님이 쓴 논문에서 스테이지가 올라감에 따라서 스테이지가 1, 2, 3로 올라감에 따라서 세그멘탈 리섹션의 생존율이 더 안 좋아지는 경향을 이렇게 보이는 그런 연구 결과를 발표를 했다고 해서 이런 것들에 대해서는 좀 이게 단순히 그냥 스테이지에 뭐가 있는 게 아니고 스테이지에 따라서 뭔가 달라지는 게 있지 않을까 이렇게 말씀하셨습니다.
Actually, I have yeah, 죄송합니다.
We only have 3 minutes. Before we wrap up, I just ask a simple question. It's a 20. Just for example, 52-year-old male, the 10-year history of ulcerative colitis. He has very limited dysplasia with cancer, dysplasia-related cancer, and he is very healthy. He has no community. What kind of surgery do you recommend him? It's a question. Okay, just how about Dr. Ueshima?
Thank you very much. If that lesion is highly suspected to the UC associated dysplasia,
Yes.
and also nowadays there's a discussion between the low-grade dysplasia and high-grade dysplasia. I think low-grade dysplasia could be acceptable for the endoscopic resection, but if that's a high-grade dysplasia and highly suspected to be the UC associated, I would recommend the extended colectomy because he's a healthy young patient. Yeah.
Tsuyoshi.
It's completely the same. I think that Dr. Seishima said everything. And only one thing to add is if the dysplasia is not in the anal canal, I would still choose maybe, preserving and at least, preserving some anal mucosa. But if the dysplasia it exists in the anal canal, then I do complete full mucosectomy. That might be something. So, basically stapled versus Henderson anastomosis. That's what I'm talking. But otherwise, fully agree with him. Yeah.
이준일 교수님.
I also agree with Dan, but another point is personally, I talk with her because maybe he has some long-term survival is possible. So we discuss about her conditions because after the total proctocolectomy, and he quit the UC medication, but he need to suffer some ileal pouchitis and another something complications. So if her dysplasia place is quite limited and rectal sparing, after the discussion, maybe some choice is the segmental resection.
어때? 프로페서 김소영 교수님?
저도 비슷하게 사실은 프랙티스를 선택할 것 같고요. 사실은 젊고 다른 특별한 문제 없고 렉탈 스페어링 할 수 있을 것 같으면 이제 하는데, 사실 결국은 환자와 그런 디스커션에서 사실은 얼마나 그 수술에 대한 위험과 이런 걸 다 이제 어그리하느냐 이런 게 사실 저는 더 중요한 것 같습니다. 실질적으로 프랙티스를 해보면은 제가 아무리 이게 더 좋다고 설명을 해도 그래서 비슷한 저도 그렇게 생각합니다.
Korean doctors is so to be later discussed with patients and you know,
She was
Did
in
we
trouble.
lose her?
Yeah. So basically, she was saying that Professor Lee and Kim agrees with you guys, but emphasize more with patient discussion with a patient.
예, next, 다음 그 코리안 세션은 1월 20일에 뵙습니다. 그래서 아나스토모틱 리퀴드 토픽 디스커션을 진행하겠고요. 각 센터에서 그 대표를 하실 수 있는 분들을 모셨고, 제가 이 센터에서 발표됐던 모든 데이터 긁어서 그 아나스토모틱 리퀴즈 레이트를 모두 이제 오픈하면서 이제 저 방법, 리퀴즈를 어떻게 막는지, 뭐 어떻게 프리벤션 하시는지에 대해서 재미있게 정말 이렇게 탁탁 터놓고 얘기해보는 그런 재밌는 시간을 가져보도록 노력하겠습니다. Thank you for joining us, Dr. Ishima, and please, very thankful for sharing your good research, and Chuyoshi very thankful for your, tough schedule, joining us
Anytime.
with,
Anytime.
with your tough schedule. 김영희 감사드립니다. Thank you for joining us, Professor Jong-Yo Lee and So-Young Kim. It's very interesting and fruitful discussion. 모두 감사드립니다. 모두 좋은 밤 되시기 바랍니다. Thank you and thank you. Thank you.
Thank you.
Thank
Bye-bye.
you.
Thank you very much.
감사합니다. 1월에 뵙겠습니다.